Good evening. Welcome to the platform of Odont Academy of Learning. Today, I will be discussing the topic Endo Perio Lesions. I'm Dr. Nikita and I'm an endodontist. Endo Perio lesions are a quite common problem that we face in the clinic, and many of the times there is always a dilemma as to how to go about the treatment and where to start. So, I will be covering the topic under the following topics, that is introduction, the pathways connecting the endo and perio tissues, etiology of endoperio lesions, classification of endoperio lesions, followed by the clinical diagnostic procedures, and then therapeutic management of pulpal and periodontal diseases, followed by conclusion and references. So coming to the introduction, endoperio problems are responsible for almost 50% of tooth mortality today. So in 1919, Turner and Drew first described the effect of periodontal disease on the pulp. The relationship between the periodontium and the pulp was discovered by Simmering and Goldberg in 1964. But on a more broad basis, we know that unless the periodontium is strong, the prognosis for any tooth which is treated endodontically is always not that great. Therefore, the pulp and the periodontium are like the hand and the glove. They go together, right? Since then, the term endoperiolesion has been used to describe lesions due to inflammatory products found in varying degrees in both the periodontium and the pulpal tissues. The pulp and the periodontium are connected majorly through the embryonic, anatomic, and functional interrelationship. Now coming to the pathways that connect the endo and the perio tissues. So we have anatomical pathways and we have non-physiological pathways. As you can see in the picture here, the anatomical pathways, the first one is the apical foramina, obviously, right? The apical foramen is present at the end of the root. At the end of the root, here you can see in this picture, and also the accessory and the lateral canals. So the apical foramen, the accessory canals, and the lateral canals mostly are present in the apical third of the root, that is in the apical 3 mm of the root. You find this in abundance. So this area is very important. It holds a lot of significance when it comes to the treatment of endoperio lesions. The congenital absence of cementum exposes the dentinal tubules. Therefore, the penetration of any kind of exchange between the pulp and the periodontium becomes quite easy when there is absence of cementum. And yes, developmental grooves as well, which are present on the tooth structure, are also a type of anatomical pathway. The non-physiological pathways are iatrogenic root canal perforations. So what happens is, if the access opening has not been done properly, or if there is a perforation at the floor of the pulp chamber, or if there is a coronal perforation or an apical perforation or a zipping, then that is again a man-made pathway. It's an iatrogenic perforation which is creating a pathway between the periapical tissue and the pulp. Vertical root fractures, which are caused due to trauma or the pathway created due to any kind of resorption, either internal resorption or external resorption. So these are the non-physiological pathways. Moving on. Now, etiological and contributing factors to the endoperio lesions. So under endoperio lesions, we have two types which cause the endoperio lesion. First is the etiological factors and next is the contributing factors, right? So etiology basically means the cause. The whole meaning of etiology is cause. So under that, we have living pathogens and non-living pathogens. So under living pathogens, we have bacteria, fungi, and viruses. Whereas under non-living pathogens, we have extrinsic and intrinsic agents. So under living pathogens, mainly we have anaerobic bacteria, which constitute more than 90% of the etiological causes. There are also facultative anaerobes and rarely aerobes. Why? Because in the root canal system, as well as in the periodontium, the levels of oxygen are pretty low. Therefore, we usually have anaerobic bacteria which thrive in the absence of oxygen. Then we have Candida albicans, which is a fungi. It's an opportunistic infection. Herpes simplex virus, human cytomegalovirus, and Epstein-Barr virus type 1. So these are the living pathogens which contribute to the etiological factors causing endoperio lesions. Then under non-living pathogens, we have foreign bodies, namely dentine and cementum chips. So if dentine and cementum chips get dislodged from the tooth and they get embedded in the periodontium, that can also cause endoperio lesion. Then amalgam. If there is, amalgam which has the seeped into the periodontium, we see long-standing amalgam restorations. What happens is the amalgam tattoo, what we call, right, where there is seepage of the amalgam into the gums and into the surrounding periodontium tissues. That is the reason, another reason for causing endoperio lesion. Then root canal filling materials. So what happens is if your sealer or your katapacha point itself has gone beyond the apex, that becomes an eternal irritant because it's gone beyond the apex, so it acts as an irritant and it continuously goes on irritating the periodontium, and that could lead to an endoperio lesion. Then we have cellulose fibers, absorbent paper points, gingival retraction cords, leguminous foods, calculus-like deposits. These are all foreign bodies. Okay, these are all foreign bodies which are not supposed to be there, but they are there and they're causing irritation. So all of these can lead to endoperio lesions. Also, cholesterol, Rushton bodies, Russell bodies, and Charcot-Leyden crystals. So these are all again a type of foreign bodies, but so the Rushton bodies are basically a type of deposits. They are namely hyaline bodies. They're made of hyaline tissue, and they can cause irritation if collected at the periodontium, if they're present at the periodontium in between the junction of the pulp and the periodontium. So, and Charcot-Leyden crystals are again similar to calcific deposits which are present. If present at the junction of the periodontium and the pulp, they can lead to an endoperio lesion, right? So these are the living pathogens and these are the non-living pathogens. Now, coming to the contributing factors, that means this is the main cause. Along with this, these factors also contribute to endoperio lesions. So poor endodontic treatment, okay? Poor endodontic treatment can lead to an endoperio lesion. Coronal leakage. So what happens is after completing the root canal, many of the patients don't maintain good oral hygiene, or they don't come back for the coronal permanent restoration or for a crown. So in such cases, what happens is the coronal restoration gets dislodged, okay, if it's a temporary restoration, and leakage can occur. This can again lead to reinfection. In the cases of trauma, in cases of root resorption, either external or internal, in cases of iatrogenic perforations, developmental malformations, and cracked tooth syndrome. So all of these are your contributing factors to endoperio lesions. Okay, so moving on. Now, these are the bacteria associated with pulpitis. Under that, I have just mentioned a few species which are the most prominently associated with pulpitis. We have Eubacterium species, Peptostreptococcus, Fusobacterium, Porphyromonas, Prevotella, Streptococcus, Lactobacillus, Vollinella, and Actinomyces. So all of these are the ones which are most commonly associated with pulpitis. Among these, you can see in the chart here, gram-negative are pretty common as compared to gram-positive. There are more number of gram-negative organisms associated with pulpitis. And these are the number of strains for each bacteria present. Okay, so a little more information about this. Moore and Sundquist, okay, what they did is they conducted a study and they said that most of the species that have been found in the infected root canals can also be present in the periodontal pocket. So they are saying that the species of organisms, the microorganisms causing pulpal disease can also cause periodontal disease. So both of them are interrelated. Roof et al. Studied the profiles of periodontal pathogens in pulpal and periodontal diseases associated with the same tooth and concluded that periodontal pathogens often accompany endodontic infections. Didilescu AC et al. In 2012, they said that F. nucleatum, P. micra, and C. sputigena play a role in the pathogenesis of Endo Perio lesions. So these are a few studies conducted by various scientists showing the connection between pulpal and periodontal disease. Now coming to the classification of endoperio lesions, we have total 4 types of classifications. Number 1 is based on etiology, diagnosis, treatment, and prognosis given by Simon, Glick, and Frank in 1972. So under that we have primary endo lesions, primary endo with secondary perio, primary perio lesion with secondary endo involvement, and finally we have true combined lesions. Now, the next classification was given by Wien, and it was based on the the clinical presentation strategy for each. So it had 4 classes. Class 1, tooth in which symptoms clinically and radiographically simulate periodontal disease, but in fact, they are due to pulpal or necrosis. Class 2 was tooth has both pulpal or periapical disease and periodontal disease. Class 3 was tooth has no pulpal problem but requires endotherapy plus root amputation to gain periodontal healing. Class 4 was tooth that clinically and radiographically simulates pulpal or periapical diseases but in fact has periodontal disease. So this was based on the clinical presentation that Wien had classified. Now coming to the stock modification of Simon's classification, he removed class 5 and he said that both class 2 and class 4 in advanced stages actually become true combined lesions, and therefore a separate class is not required for this lesion. So he omitted class 5, which is true combined lesion. Grossman classified endoperio lesions based on treatment plan. Type 1 was requiring only endo treatment, type 2 requiring perio treatment only, and type 3 was requiring both endo and perio treatment. Now coming to the classification as recommended by World Workshop for Classification of Periodontal Diseases, the first one was endoperio lesion, second one was perioendo lesion, and finally we have combined lesion. Now, coming to the most important part of this topic is the diagnosis. How do you diagnose an endoperio lesion and how do you treat it? So the first thing that we do is examination. Under that comes visual examination. So I have put it in a stable form for you to understand, and it's pretty self-explanatory. The primary endo lesion, okay, let's start with this. In the primary endo lesion, in the soft tissue, there could be a sinus opening. Along with this, you can see tooth decay or a large restoration or a fractured restoration or erosion or abrasion or crack or discoloration or poor RCT. So there will be definitely some etiology in the tooth structure. There will be an etiology in the tooth structure, some problem in the tooth, and in the soft tissue, sinus opening is usually seen. It may or may not be seen, but yes, if it is present, along with this, it is a primary endo lesion. In the primary perio lesion, what we see is, we'll see inflamed gingiva, you can see recession, you can see plaque and subgingival calculus associated with multiple teeth. And there could also be swelling indicating periodontal abscess with respect to that tooth. So this is clear cut, okay? Primary endo and this is primary perio. Now coming to primary endo with secondary perio involvement, plaque forms at the gingival margin of the sinus tract leading to inflammation of the marginal gingiva. So it's primary endo. That means the cause, the problem has started from within the tooth, okay? That means endo involvement happened first. Plaque forms at the gingival margin of the sinus tract, leads to inflammation of the marginal gingiva. You can see exudate there, and root perforation or fracture is also seen. So the etiology is endo-related. That means the tooth is causing the problem and not the periapical tissues. Coming to primary perio and secondary endo, you will be able to see plaque, maybe subgingival calculus, and swelling related to multiple teeth. Pus and exudate will be seen, localized or generalized recession and exposure of the root. So here the cause of the endo problem is not endo, but it is perio-related. That means the lesion began in the periodontium. Okay, the problem began in the periodontium, and how does that like what indicates that is basically this. When you see subgingival calculus, it's a very strong indication that periodontal lesion has come first. Okay, periodontal lesion is the culprit here, and that has led to swelling and pus and exudate and generalized recession, exposure of the root. Okay. Now, when we come to true combined lesion, it's very difficult to tell which came first. Okay. Did the perio start first or did the endo start first? Because here in the primary endo, secondary perio and primary perio, secondary endo, what happens is you can see in the varying degree of infection. Okay. The perio infection will be more than the endo infection in this case, whereas the endo infection will be more than the perio infection in the first scenario, in this scenario, as you can see, I'm showing you on the laser pointer. In the true combined lesion, you will see the features of both of these actually. There will be plaque, there will be calculus, there will be periodontitis in varying degrees, as well as swelling around single or multiple teeth, and pus and exudate as well. Okay, and the tooth may have also become non-vital. The tooth which we are going to do the treatment for, that also could have become non-vital. Okay, now, so this is, but that you cannot tell under visual examination whether a tooth is vital or non-vital. That cannot be judged in the visual examination. So now moving on to the next part is the pain. Okay, so you're done with the visual examination. The next thing that we have to do is to check for pain. In a primary endo lesion, the pain will be very sharp. The patient will come with you and say that, I'm not able to sleep, I'm not able to eat, I'm not able to do anything. The pain is unbearable, please do something. Okay, that is because in a primary endo lesion, the pain is coming from the pulp, and the pulp is a very small chamber. Okay, so the infection is building up, but it doesn't have any place to come out, right? That is why the pain is always sharp in a primary endo lesion. In a primary periolesian, usually the pain will be dull and it is sharp only when it's an acute condition. Okay, it's usually dull and it's not continuous stabbing type. It's usually dull throbbing type. It will be sharp only if it's a acute condition. In primary endo, secondary perio, usually the pain will be sharp shooting and dull ache in chronic conditions. Okay, because primary is endo. So when primary is endo, usually pain is always sharp. Whereas in primary perio, secondary endo, it will usually be dull ache, sharp only in the case of acute periodontal abscess. So only in acute cases it will be sharp. In the true combined lesion, same thing, it will usually be dull ache, but only in acute conditions it is severe. Okay. Now coming to palpation. Palpation in the primary endo lesion will not tell you whether the inflammatory process is of endodontic or periodontal origin. Okay, when you palpate, you cannot tell anything in a primary endo lesion, because in a primary endo lesion, the periodontal tissue is not involved. So when the periodontal tissue is not involved, palpation doesn't really make sense here. It will not tell you whether inflammatory process is belonging to the endo part or to the perio part. In primary perio, you will see pain. Primary endo, secondary perio, also there is pain. Primary perio, secondary endo, also there is pain. And in true combined, also there is pain. So except for primary endo lesion, palpation elicits pain in all the other conditions. Coming to percussion, in primary endo, it is normally tender on percussion, and in other all conditions, tenderness on percussion is elicited. Now, in primary endo, only if there is not even a little bit of infection in the periodontium, that means it is still in the pulpitis stage. Okay, it has not proceeded to go to the periapex and become apical periodontitis. It is still in acute pulpitis or chronic pulpitis stage. In such a situation, usually tenderness will not be elicited, or it will be very, very mild. But if it has gone to the periapex, definitely there will be tenderness on percussion. So in normal situations, yes, tenderness on percussion will be there, because mostly in a clinical scenario, patients don't come to you in the stage of pulpitis. They come to you only when it has gone beyond the pulp, it has gone to the periapex, and the pain becomes unbearable. Okay, that is why we say normally tender on percussion. So in all the scenarios, it is tender on percussion. Okay, coming to mobility, in primary endo lesion, fractured roots and recently traumatized teeth often present high mobility. Okay, so in the case of a fracture, or when there is a trauma, like let's say the patient has eaten something hard. Okay, patient has eaten something hard very recently, and he comes to you and says that, you know, I'm having pain in this tooth. If you check that tooth, it will also be mobile. Okay, why? Because of the trauma. The trauma has caused a direct injury to the periodontium, which has affected the strength of the root, right? That is why there will be mobility. In primary perio, localized to generalized mobility of the tooth will be there, because definitely if the periodontium is compromised, there will be mobility in the teeth. Primary endo, secondary perio, there will be localized mobility. Okay, because it's primary endo and secondary perio, only the tooth which is affected, only that tooth will have mobility. Whereas in primary perio and secondary endo, there will be generalized mobility, because primary perio means primary perio, there will be multiple teeth affected, not only one tooth. Okay, so it is generalized mobility. In true combined lesion, generalized mobility with higher grade of mobility related to the involved teeth. That means there will be generalized mobility, but the tooth which has endo problem as well, there you will see higher grade of mobility. Now coming to the pulp vitality test, as I spoke before about the vitality, I'll explain in detail now. In the pulp vitality test, there will be a lingering response in the case of primary endo lesion. Lingering response means irreversible pulpitis. That means, let's say you're doing a cold test, okay? You place the ice cube, or you place the carbon dioxide snow stick on the tooth, and the patient says, I have pain, I'm feeling sensitivity. Even after removing the stimulus, that means even after taking out the stimulus, that is the ice cube or whatever you're using to conduct the cold test, when you take it out, the patient still says, I have pain for more than 10 seconds after removal of the stimulus. This means that the tooth is now in the stage of irreversible pulpitis. Okay, so either it will have a lingering response or it will have no response. That means it's a necrotic pulp and it has become non-vital. Okay. Now coming to primary perio lesion, in the primary perio, the pulp is vital because it is not involving the endodontic part of the tooth. It is not involving the pulp yet. So the pulp will be vital, and only the pulp will be vital, and it will have all the positive responses to whatever test we are conducting, whether it's cold test or a heat test or electric pulp test. Any test that you conduct to check for vitality, it will give a positive response. Now, coming to primary endo secondary perio, primary endo secondary perio means already the infection has gone to the periodontium. It has bypassed the pulp and gone to the periodontium. So pulp test will be negative. In primary perio secondary endo, pulp vitality can be positive in multi-rooted teeth. Why? In multi-rooted teeth, what happens is many of the times one of the roots could be still vital, whereas the other two could have become necrotic. So it is like all the three roots, or let's say two roots in the case of premolars and three roots in the case of molars, depending on which molar you're doing. What happens is the each root will not go and become non-vital at the same time. Sometimes some amount of vital pulp tissue could be retained in the pulp chamber or in one of the roots, even after the necrosis occurring in another root, right? So in such cases, you get a false positive response. So in this false positive response case happens in primary perio and secondary endo lesion in the case of a multi-rooted tooth. In a true combined lesion, that means now it is a more advanced state. So in an advanced state, you will usually get a negative response because now the entire tooth would have become non-vital. Okay. Right. Coming to pocket probing. In the case of an endo lesion, you will see a narrow, deep, solitary pocket. Okay, a narrow, deep, solitary pocket. That means only in one particular area you will see the pocket. In primary perio, you will see multiple wide, deep pockets. In primary endo, secondary perio, there is a presence of solitary wide pocket. In the case of primary perio, secondary endo, presence of multiple wide and deep periodontal pockets are seen. Excuse me. In a true combined lesion, probing will reveal typical conical periodontal type of probing. So this is a characteristic finding in a true combined lesion. Probing reveals typical conical periodontal type of probing. Okay, moving on. Coming to sinus tracing. In the sinus tracing in the primary endo lesion, a radiograph with GP points to the apex or furcation area in the molars. So in the sinus tracing, we use a GP point and the GP points to the apex. So when it goes to the apex, that means it's a primary endo lesion. In the primary perio lesion, the sinus tract is mainly at the lateral aspect of the root. So when the GP point goes to the lateral aspect of the root, it means it's a primary perio lesion. In the case of a primary endo and a secondary perio lesion, the sinus tract is seen mainly at the apex or at the furcation area. And in primary perio, secondary endo, sinus tract is mainly at the lateral aspect of the root. So please remember, in the case of a primary perio lesion, the sinus tract will be mainly at the lateral aspect of the root, either here or here. Whereas in the case of a primary endo lesion, you will see the sinus tract at the apex or at the furcation area. In a true combined lesion, it will be difficult to trace out the origin of the lesion. So in true combined lesion state, sinus tracing does not hold much of significance. Now coming to, I've put in a couple of radiographs here for you to understand better. So in the primary endo lesion, okay, it looks like this. So this is, there is a filling over here, as you can see. Probably it's a long-standing filling. And even though in the picture it looks like it's not involving the pulp, in practicality, it probably is involving the pulp, which has led to, you can see here, there is a big lesion on the distal root. And in the mesial root also, there is widening of the periodontal ligament space. Okay, so this has happened because of primary endo. Coming to primary perio lesion, you can see in this picture, this is the tooth which is causing the, which has a lesion here. It's quite a large lesion, but you can see that the tooth is intact, right? You cannot see any filling or any caries or anything, and you can also see bone loss. Generalized bone loss is there according to this radiograph, and there is a lesion with respect to this premolar. Okay, so this is your primary perio lesion. Coming to primary endo and secondary perio, so you can see that there is a perforation which has formed here. Okay, it has gone through the furcation area. The dentist has probably attempted to do a root canal treatment, but maybe he has not been successful. They've placed a crown, okay, and they've created this iatrogenic perforation here. So the main problem started with endo, and now it has become secondary perio because of this iatrogenic perforation, okay? And you can see bone loss here on the mesial aspect as well as the distal aspect as well as in the furcation area. Coming to primary perio, secondary endo, you can see in this picture here, okay? This has the main cause here, okay? You can see this big lesion which is formed. This lesion has led to the destruction of the pulp. Okay, so there is it's basically retrograde infection. So what happens is, when the infection spreads from the periodontium into the pulp, we call it as a retrograde infection because it's coming from behind. Whereas when there's an infection which goes from the pulp into the periodontium, it is called as an anterograde infection. Okay, so you can see here there is also widening of the periodontal ligament space all along the root structure as well as at the apex. Okay, so this kind of signifies, it shows you, as I said before, there was a point where we said that in primary endo lesion we see solitary confined deep pocket, right? So if you combine that And if you correlate that with this X-ray, there is a deep pocket here on the distal aspect of this premolar, as well as there's a lesion at the apex. Okay, so it's a primary perio followed by secondary perio. It's a primary perio followed by secondary endo. So main cause is the periodontal destruction, because you can see there is no problem with the tooth. The tooth is intact. Okay, so the primary perio has led to secondary endo infection. That means the pulp probably is now non-vital in here. Coming to true combined lesion, you can see in this picture, here you can't really tell which came first, okay, whether it's the perio or it's the endo. It's quite advanced stage. This tooth is practically hanging in air now, okay. You can see there is severe bone loss on either side of the tooth, in the mesial aspect as well as in the distal aspect. And there is also significant widening of the PDL space at the apex, okay. So this tooth has probably undergone some kind of trauma, or something has happened in the past, and it looks like it's also supra erupted. If you compare with the adjacent teeth, the height of this tooth, the level of this tooth is still up, okay. So it looks like it's also extruded out of the socket. It's supra erupted, and it has lost its entire periodontal support, and definitely it will be non-vital, okay. So now coming to cracked tooth testing. When you check for cracked tooth testing, it will have painful response on chewing. Painful response on chewing in the case of a primary endo lesion. In the primary perio lesion, there will be no symptoms. In case of primary endo, secondary perio, painful response will be there on chewing. Primary perio, secondary endo, there will be no symptoms. In true combined, again, there is painful response on chewing. So cracked tooth testing is done with the help of a tooth sleuth, where the tooth sleuth is placed at the occlusal table and the patient is asked to bite on the tooth sleuth. And when the patient bites, at that point he feels that there is pain, okay? So that is cracked tooth testing. This is in the case of a normal tooth. If there is a cracked tooth, then the pain will be there when the patient releases his bite. Okay, when the patient releases his bite, at that time there will be pain in the case of a cracked tooth. Whereas in normal situations, when there is no crack, okay, the tooth is intact, there's no fracture or crack, at that time there will be painful response upon chewing and not on releasing. Okay, so this painful response on chewing is seen in primary endo with secondary perio, and in true combined lesion. Right. Now coming to the treatment aspect. Okay, so treatment aspect is broadly divided into three types. First is in the case of a primary endo lesion, then in the case of a primary perio lesion, and finally in the case of a combined lesion. So in the case of a primary endo lesion, we perform endotherapy. That's it, okay? Perform root canal therapy and you save the tooth. That's the only treatment to be done. In the case of a primary perio lesion, we perform periodontal therapy. So either scaling and root planing, followed by any other deep curettage or pocket therapy, depending on how much the periodontal destruction has occurred. So we perform only periodontal therapy. Now, in the case of a combined lesion, it is again divided into two types. Combined lesion mein first type is primary endo with secondary perio, and then we have primary perio with secondary endo and true combined lesions. So in the case of primary endo with secondary perio, the first thing we do is treat with endo. So the first treatment to be done is RCT or root canal therapy, and then simple hygiene phase therapy, that is oral hygiene maintenance. Then you evaluate again after 2 to 3 months, and if required, that means if the lesion has not resolved by then we perform periodontal therapy, that is pocket therapy. Okay. Now, if this has occurred because of iatrogenic damage or fracture or perforation of the root, you have to seal the perforation with a suitable material. So perforation repair materials are available in the market, like MTA or Super EBA, GIC, Vitrimer, whichever is available in the market and easy for you to procure. With that, you have to seal the perforation, and then we have to manage the root fracture. Now, if it's a vertical root fracture, the best solution is to extract the tooth. Vertical root fractures have poor prognosis in general, and anything you do, it is very difficult to save the tooth because the patient will keep coming back to you and saying that I have pain. So the best thing to do in the case of a vertical root fracture is to extract the tooth. Okay. And in the case of primary endo-secondary perio, you have to keep in mind that we have to follow multi-visit endodontics. It is better to always do multiple visit. Single visit endo is not going to help here, okay, because you will not be able to eliminate all the bacterial load in one appointment, right? So multi-visit endodontics and the use of intracanal medicament is advocated in the case of primary endo with secondary perio lesions. Now coming to primary perio with secondary endo lesion and in the case of true combined lesions. So if required, regenerative process is done, that is GTR, guided tissue regeneration. Prior to surgery, palliative periotherapy and root canal treatment is done. So first thing that what we do is you go for scaling and root planing and curettage, and then we do root canal therapy. After that, if necessary, we go for GTR. Then again, we reevaluate after 2 to 3 months. So after 2 to 3 months, when you reevaluate, in the case of periapical resolution, that means the lesion has now subsided. If tooth has more than grade 1 mobility, then we go for splinting. Okay, then we go for splinting. If there is no mobility, but periodontal pocket is greater than 4 mm, then non-surgical maintenance is advocated. Okay, in the case of no mobility, periodontal pocket greater than 4 mm, you go for non-surgical maintenance. That means the patient is just told that maintain oral hygiene. You have to tell them all the oral hygiene maintenance techniques. Then, if periodontal pocket is greater than 4 mm and less than 6 mm, then shallow defect is present. So then the patient has to undergo osseous surgery to cover that defect. And if periodontal pocket is greater than 6 mm, then it's a deep defect and GTR is required in this case. Okay, GTR means guided tissue regeneration. After performing all this, what we have to do is we have to recall the patient every 3 months, then 6 months and 12 months for a follow-up to check for the condition of the tooth. Okay. Now, after doing these two steps, the first two steps here, that is after performing RC, after performing palliative periodontal treatment, if there, then you reevaluate after 2 to 3 months, there is no periapical resolution. In such case, in the case of a hopeless prognosis, that means the tooth is not responding to the treatment that you have done, then you go for an extraction. Okay, you go for an extraction. If not, if the patient is saying no, do something, just save the tooth, I don't want to get the tooth removed, I need that tooth, I'm scared of extraction, blah blah blah, then what we do is you do a root resection or a bicuspidization or a hemisection procedure. All of these are endodontic surgeries or periodontal surgeries associated with each other. So root resection means you remove only one part of the root which is infected. Okay, in a multi-rooted tooth, you remove only one part of the root which is affected. Bicuspidization is creation of two premolars from a molar. Okay, this can be done in the case when there is a defect in the furcation area. When the defect is in the furcation area, what we do is we split the tooth from the center and we create two separate teeth so that it becomes easy for that area to be cleaned, to make it basically a self-cleansing area. Okay, and finally we have hemisection. So in hemisection, what we do is we only remove one half of the tooth. Okay, entire half of the tooth is removed. In root resection, only the root portion is removed. Okay, the crown is still saved. Whereas in hemisection, the portion of the root as well as the crown which is infected is completely removed. So let's say you have a mandibular molar. In a mandibular molar, the distal half of the tooth is infected. So the distal part of the crown as well as the root together, they are extracted and the mesial half is retained. Okay, so these are the procedures that are mentioned here. So after doing this, you do a GTR procedure. After performing these surgeries, we do a GTR procedure, and then again the same protocol is followed. That is after 3 months, 6 months and 12 months, follow-up has to be done. Okay, right. So in conclusion, I would say that a perioendo lesion can have varied pathogenesis, which ranges from simple to relatively complex one. To make the correct diagnosis, the clinician should have a thorough understanding and scientific knowledge of these lesions. So despite the segmentation of dentistry into various specializations, clinicians will have to perform restorative, endo, perio, and it could be also combined, okay? So to achieve the best outcome, especially in a case of an endoperio lesion, a multidisciplinary approach has to be involved, okay? One single clinician cannot do this. It's always better to take multiple opinions and to do it as a combined therapy, right? Okay. So these are my references for this topic. Thank you so much. I'm glad to have shared this knowledge with you, and I hope that it helps you greatly. Thank you so much.